Hi, so we're just going to run through some high-risk postpartum and high-risk newborn. We're starting with high-risk newborn. Oh, gosh, I hate looking at myself, but here we go. All right, so high-risk newborn. Can't see the PowerPoints, but I just want to highlight some of the important things that the PowerPoint explains. We are going to talk briefly about a number of newborn complications, starting with neonatal substance withdrawal. Unfortunately, neonatal substance withdrawal is more common than you would think, and any drug mom does can certainly cross the placenta, leaving baby needing a fix after his supply has been cut off with birth. So initially, our concern is any birth defects related to the substance use during pregnancy, but in terms of the newborn, the complication is supporting them through their addiction and withdrawal. Fetal alcohol syndrome certainly occurs. I don't see it as much as I see the withdrawal from opiates. But fetal alcohol syndrome itself is considered a syndrome, and there are definitely some physical defects that once you see, recognize what an FAS baby kind of looks like. There's some neuro dysfunctions, there are behavioral difficulties, which is probably the most difficult to deal with. And definitely some delays intellectually. So here's a picture, there's a picture in the PowerPoint of some of the associated features of a fetal alcohol syndrome child, facial differences, if you will. And then the next slide shows an actual picture of a baby with fetal alcohol syndrome. And once you become familiar with that picture, it's easier to recognize children who have been exposed to alcohol in utero. You have your withdrawal from opiates, including Suboxone and Methadone, which is what we use legally to get pregnant women off of illegal drugs. It ranges, there's neuro, behavioral, physical signs, and we have to really monitor for all of them. Anything from increased muscle tone to seizures in terms of the neurological stuff. They have this high-pitched, unrelenting, unrelieved, uncontrolled, inconsolable cry that can get to you pretty quick. What we do for them basically is feed them. They are notoriously lousy eaters. They, uncoordinated suck and swallow. But we have to try to make sure that they're getting their proper nutrition anyways. And we decrease any external stimuli that we can. Darkened room, quiet area, swaddled up tight, that sort of thing, to really keep the stimuli to a minimum. And they like to be held, just held and rocked gently. It's pretty heartbreaking to see. But they can certainly withdraw from any number of substances. The big ones we think of are heroin and that sort. But I see babies withdrawing from nicotine. About the 24-hour mark, they're pretty cranky. I don't think it's associated with any major physical withdrawal, but I definitely see them pretty cranky at the 24-hour mark. And like I said, now we're moving more towards eat, sleep, and console. We still do that. We have to monitor them for, because we don't want them having a seizure. We don't want anything along those lines. So we just have to manage their symptoms really as best we can. As I said, we're moving more towards not medicating, but some hospitals are anyways. That's the trend. But there's such a thing as called a Finnegan score. I don't know if that's on the next page. No. Finnegan score is the objective table, if you will, what we're using to kind of grade a baby's withdrawal. And we use the total score to help guide in what we're going to do for the baby. And I think that us old nurses are still kind of running through the Finnegan score in our head, grading the babies to try to figure out if this eat, sleep, console thing is working or if they need something else. Because we still have to keep that baby safe. And if we think that baby is heading towards seizure or they are not taking in as many calories as they are burning off and they're wasting away a bit, we need to intervene with some sort of medical. The other issue is the DCF involvement. We are mandated reporters as newborn nurses when there's any sort of drug use at all during pregnancy. That we have to contact DCF and they carry out an investigation. I think the biggest challenge, other than trying to keep these babies, or trying to keep these babies happy, which is beyond our control, but keeping them safe. The biggest issue really is not being judgmental towards the mother. Honestly, we have a mom who might be coming and going because she's already been discharged from the hospital, leaving us with becoming the primary caregiver, if you will, of the baby, or that we're holding that baby, trembling in our arms, and trying to console a baby that's inconsolable, and then mom comes in, for a visit or whatever. It's hard not to judge them. It's hard not to blame them, and so that's, I think, is the biggest challenge. And so very important to not judge them, because that's not for us to do. I spoke of earlier that a lot of drug use is from, there's an underlying mental health issue. So whether it's anxiety or depression or something like that, it's also probably already a low self-esteem issue, right? So who am I to judge and treat them poorly? We are just complicating the issue, We have to remain as objective as possible in dealing with this special population of patients. And we have hypoglycemia. Hypoglycemia is a concern for a couple of different reasons. Hypoglycemia in a term newborn is considered 40 milligrams per deciliter or below. Some hospitals are moving more towards 45 milligrams per deciliter. So it depends on where you're at. There are certain babies who are more at risk for hypoglycemia, certainly the large for gestational age, the small for gestational age, and the mother who's diabetic. So the baby of a mother who's diabetic. Those babies are used to having some nice sweet blood. They don't get it anymore. So we just have to watch those babies. By the way, a baby with a blood glucose, a preterm baby, is considered hypoglycemia if their blood glucose goes below 25. So a little bit different there. Untreated hypoglycemia can it's not just a little cranky baby who's a little jittery. It can lead to up to death, seizures, brain damage, and or death. So it's no joke. Most often what we see is, again, a high-pitched cry and jittery. Jittery, disturbed, undisturbed. It doesn't It's not about being startled. It is a jitteriness that stays no matter what you do. Sometimes I also see low blood sugar babies have a decreased temperature with no other reason for it. So if the baby's all wrapped up tight and I get a low temperature, I might check a blood glucose because one might be causing the other in either direction. So, and we already talked about the different risk factors. The other one is stress. Stress at birth, cold stress. That's where the temperature thing comes in too. Maternal epidural anesthesia is considered a risk factor, but that's never come into my thinking, and it's not part of any protocol like check a blood sugar if mom had an epidural or anything like that in my experience. Although my experience is limited, I must admit, 28 years is not nearly long enough. Preterm babies also are often small, but preterm babies just have to figure out so much and so quickly without the benefit of cooking a little bit longer. So we're watching their blood sugar as well. So yeah, they're feeling pretty lousy. Has anyone ever felt like their blood sugar was dropping? You know how you feel? The shakes. I get sweats, anxious. I get a little bit anxious, and shaky. So the babies pretty much are doing the same thing. We stick their heels just like it's like a finger stick, but just on their little tiny baby heel.
What's a gavage feeding?
Gavage feeding is like a tube feeding.
Oh,
Mm-hmm.
I meant to bring it. I have the tube. I have a bucket of her
Stuff. Yeah.
We didn't ever have to use it, but they had packed a bunch of
Mm-hmm.
stuff supplies that they thought they were going to use that they probably charged to us anyway, so they threw in the bucket and sent home, and it's a little
Tiny little tube stuck down there. It can either be an NG tube or an OG tube, but yeah, the NG tube is actually more likely to get into your belly and get out of the way of any sort of mouth stuff. But yes, that's the gavage feeding. Respiratory distress syndrome. Back when we were talking about preterm labor and stuff, we talked about betamethasone, help or hastening fetal lung maturity, that sort of thing. We talked about the lecithin-sphingomyelin ratio with the amniocentesis and all that. All of that is what we're trying to do is have baby have enough surfactant. The surfactant kind of, how do I put it? It relaxes all the alveoli and stuff so that when air enters the lungs, they pop right open and do what they're supposed to in terms of gas exchange. A baby lacking in surfactant or deficient in surfactant, they're too stiff and not able to expand like the bubbles that they are. So we're gonna definitely have some poor gas exchange with these babies. And some babies can fool you. They look older, but they're not. So that's where the gestational age assessment stuff comes in, right? So we gotta work on these kids, support them as best we can. Sometimes they're breathing, but they're getting really, really tired. They're grunting. Do I have that on that page? No. They are grunting. Which sounds like a cooing. It doesn't sound like a wrestler grunting. We have some retractions and some nasal flaring and that sort of thing, and they're working really, really hard to maintain, and they're going to get tired and decide they're not going to do it anymore. Complications from respiratory distress syndrome certainly just make matters worse for any newborn baby, especially the preterm newborn baby. The younger they are gestationally, certainly the more at risk they are for this respiratory distress syndrome. And there's some other risk factors there as well. Yeah, there it is. Some of the stuff you might hear some crackles on the lungs when you're listening. You might see some more cyanosis. We have the acrocyanosis, which is the bluish hands and feet, which is actually pretty typical, normal of a healthy newborn, first 24 hours. But then we have circumoral cyanosis. So you're going to have the bluish tint like around the mouth and that sort of thing. Those babies are struggling for oxygen. We got to rule out infection. We have to rule out that sort of thing, and get these babies the help they need, which is that surfactant and respiratory support, while they are maturing their lungs on the outside. Preterm baby, we know a preterm baby is a baby born after 20 weeks and before 37 weeks. All right, depending on where they are, in their gestation and what kind of conditions they had ahead of time will depend on what we have to do to support them in their growth afterwards. It's been my experience, and it's just my experience, that some babies who have struggled in utero for some time, like maybe mom has a high blood pressure issue and the placenta has been giving her some trouble for a while. Sometimes I think these babies do better on the outside than another baby who was just born like everything's going well, and then they get born premature, kind of on short notice. The babies who have had some chronic issues, I think, are stronger, and they do surprisingly well outside compared to the babies who maybe were taken early for some other, like I said, acute and short-term issue, where maybe they thought they had more time. But I don't know. It's just been my experience. Anyways, preterm babies, certainly. The extreme premature babies certainly have a host of issues, breathing, thermoregulation, eating, you name it. They're being wholly supported. It's I don't know, pretty scary when you can hold a baby in the palm of your hand. Babies about a pound have survived and thrived. For those who had babies in the NICU, you saw these tiny little creatures. I have a friend right now whose daughter had a baby 26 weeks, and I just saw a picture the other day of that baby. Yes, she has a tube still in her nose, a feeding tube in her nose. She's off the respirator, and she was giving the biggest, most heartwarming smile for the camera or whoever was behind the camera. And it's just amazing. To me, it's just amazing that this child is surviving and doing as well as she is, which is great. They have a lot of hurdles. They, to certainly go across.
Watched so many progress and then they fall back.
Yeah.
And then they put up their little,
Right. They could be doing really well, and then all of a sudden they get that infection, that necrotizing enterocolitis seems to be the thing that I'm thinking of. Intraventricular hemorrhage. I mean, that can kind of occur more spontaneously. We are monitoring them for apnea. They kind of forget that they have to breathe on their own, and so they don't.
Like countless times, like the bells and whistles would go off, and a team of nurses would be there with the little bamboo bag.
Yeah. It is crazy. Pretty scary if you ask
really
me.
is.
Everything is so much smaller. Micro, yeah, little tiny bamboo bag, right?
Yes.
It's pretty scary. And they're practically transparent. You know what I mean? You can see the whole network of their blood vessels. Just think about that. The skin there's no subcutaneous fat. Their skin is so very thin. It's no wonder they have trouble keeping up their core temperature, right? That's why we have to create this environment around them that keeps everything cocoon, keeps them protected from this outside world. The whole world, right? It's pretty. I think it's still pretty amazing. We're doing much better in terms of preventing or minimizing retinopathy of prematurity. It's related to oxygen use. We've really decreased our oxygen use in this population, in newborn population in general. And in doing so, I think that retinopathy has, the rate of retinopathy of prematurity has decreased. So that's good.
What about the oxygen causes of retinopathy? Is it,
I'm not sure if it's increases the intraocular pressure or something along those lines. I'm not exactly sure what it is, but you know, we think more oxygen the better, when in fact, no, not with premature babies.
okay.
It's not. Most recently, I learned when I was being recertified for neonatal resuscitation this summer, I learned that when we are doing positive pressure ventilation on a newborn, like a full-term newborn baby, that 21% oxygen, which is room air, is adequate. What we're looking for is the positive pressure. They don't want added oxygen because then they won't breathe on their own. Yeah. We're giving them what they need and they're not going to go get it themselves, kind of a thing.
Yeah.
So that's fairly new in the last few years. So we're even avoiding oxygen use during resuscitation. But nothing's yet done cooking, right? So we got some heart issues, patent ductus arteriosus, GI issues with the inflammation, if you will, of the GI mucosa, with the ischemia, you know, the blood supply really to the area. Their liver is not mature enough. It's not necessarily passing and clearing and metabolizing all that extra bilirubin running through. So they have problems with jaundice, anemia, hypoglycemia. I mean, there's so many hurdles that they have to cross, and you never really fully. I doubt you ever really fully relax until they are given the all clear to go home, and even then, I can't imagine relaxing for another few months after that.
They stay tiny forever. There was a girl in our cohort that was a preemie, and she was a tiny, I think she was about that, because I haven't seen her in a few semesters. If you remember, she was just a tiny, tiny little thing, and she had said that she and her twin were preterm.
Sometimes I have not necessarily seen an adult. Well, maybe I have. I don't know, but I have seen young children, like, you know, early school age children. I could look at them and say that was a preterm baby. You know what I mean? Their faces are narrower and longer, and they got a fight in them. They got a fighting in them. They got some sass in them, though, that always warms my heart when I see. But there's definitely, you can kind of see, not necessarily everybody, but there's a certain look, and I suppose that translates into an adult or young adult as well. So that Ballard score we talked about before, that's so important. We want to know where they are gestationally, and we will be able to anticipate what we do for them, or anticipate what might be an issue for them. And by doing this Ballard score, we're also catching the babies who are large or small for their gestation. They're not going to trick us the way some of them can, right? That large for gestational age baby who's actually 36 weeks might have trouble maintaining their temperature or their blood sugar or something, when what they look like to us is a normal, healthy newborn. So that's why the Ballard score is so important. You know, you just go through, and I think most of this, whether you know for sure or not, I think most of the stuff that you can read in these slides are pretty intuitive. Why they might have trouble. I mean, if they literally were not done cooking, that bun came out of the oven just a little too soon, or a lot too soon, and so they are having to learn how to do all the stuff that they have yet to even have developed to do. So, you know, fight off infection, keep enough fluid on board, eat, flex their muscles, also suck and swallow. When does that reflex come? Was it after they were after when they would have been born or were born? Also, all sorts of things. So depending on what we're dealing with will depend on our plan of care and course of treatment. Oftentimes we can predict. They come in, we try to stop the labor, but we can't, and then they deliver. We're going to do our best to minimize injury from birth and really support them right from the very start of life. If we can get to that mom ahead of time, we're going to give her that betamethasone to help with lung maturity. If we can get one dose into her at least, that might help with intraventricular hemorrhage and necrotizing enterocolitis. There's a tiny little newborn. That doesn't really show, because you don't have anything to compare it to.
It's probably the smallest diaper
Yeah,
you make.
that's true.
So cute.
I'm not going to go through SGA much because we already know, we kind of talked a little bit about that. Just know that these babies, if they're small for gestational age, something was lacking in utero. That's probably why they're small for gestational age. So their placenta wasn't earning its keep, right? So there could be some developmental issues, not just small for their gestation, but what else got kind of forgotten about with the placenta not working great. And socially or whatever, maybe mom didn't provide a great environment. So there was smoking, drug use, malnutrition, that sort of thing. So, we have that whole issue as well. SGA is considered less than 10% of the average weight per their gestation. And they look pretty, they look like angry old men with a thyroid issue. They're cute. Very wide-eyed and alert. I think they've had to fight for their life in utero, so they're a little bit strung tight. Like, oh my gosh, you'll never believe what just happened. Okay, so that little guy, that's the small for gestational age, and I think that's actually a normal, average gestational age baby, yeah. Yeah, so again, we just need to support them as best we can, making sure their blood glucose and their temperature and their eating, all right, their caloric intake, their nutritional intake is adequate to support their growth. Want to make sure they're breathing and all that on their own as well.
You would not find normal reflexes
In a
or SGA.
Some of them might, it depends on how early they are. It probably said somewhere when some of these reflexes actually were developed in utero. I can't tell you off the top of my head when certain ones are. I do know that an extremely premature baby doesn't suck very well, so it must have been, it must be early third trimesters or something like that. So they may have some and not others. It depends on when they are considered developed in utero. So we just have to support these babies and monitor for possible complications, infection, skin breakdown, making sure their hydration and nutrition status is adequate, that sort of thing. Maintaining a neutral thermal environment, huge. Large for gestational age, that's any baby born 4,000 grams and above, which is 8 pounds, 12 ounces, I think, 4,000 grams. So that's a lot of babies, actually. These babies, if they've survived the birth, meaning they might have gotten stuck on the way out and had a little trouble, or maybe born by C-section, that's great. If they survived that, they still might have some injuries, clavicle fracture, shoulder dystocia, all sorts of things. So the concern is twofold. One, they large for gestational age because mom was an undiagnosed diabetic? So do we have a chronic hyperglycemic environment for them, which could lead to all sorts of congenital, like heart defects and that sort of thing? And second is, if they are used to that hyperglycemia, they're going to crash. They're going to come crashing down when they're on their own to try to keep that sugar up. Hypoglycemia is the major concern for the baby of a diabetic mom in particular. That is a large for gestational age baby next to a average gestation. Yeah. Those babies can trick you. Those are the babies that might have that congenital heart defect from the hyperglycemic environment, and they look healthy, right? They look roly-poly healthy, and they're going to crash a day or so into it and give us a lot of trouble. You can read all this for yourself or listen to my awkward voiceover. And like I said, depending on what they're struggling with will depend on how we care for them. As long as we monitor all of the things we know that are common problems, their sugar, number one, their oxygenation, and their heart. You got to get them out first. So if we know a baby's large for gestational age, our concern naturally is, are they going to fit? Are they going to fit out during a vaginal delivery? Or so we're all a little on edge until that whole baby is out. And then the newborn nurse kicks in, and we start paying attention to the rest. Your post-term baby is a baby born after 42 weeks, all right? The post-mature baby is that same baby, 42 weeks or above, that are showing signs that the placenta stopped working a couple weeks before, right? So they might have even lost a little weight. They're gonna have dry, cracked, and peeling skin. They might have had meconium fluid because they were ready to poop and they just weren't born yet. So they might have meconium aspiration pneumonia. So there's some other issues with post-term babies that is concerning. There's the dry, cracked, peeling. We call it desquamation of the post-term infant. Like I said, they're not necessarily just really, really big. They could have actually started losing weight because their placenta stopped working. Depending on their presentation will depend on what we have to do. That's all I got to say about that. Neonatal infection. It can be contracted, if you will, before, during, or after birth. The one that comes to mind is groupie strep. All right, that's the one that we know very well. Is a strong possibility. We certainly see others, but the groupie strep is the first infection that comes to my mind, anyways. And if we can treat mom prophylactically ahead of time, then we are decreasing our chance of infection in the newborn. The newborn with septic newborn is nobody I'd like to come encounter, come to encounter, because they are very sick, and it's a grave situation. So there are other risk factors, certainly different infections mom might have that pass on to her baby. A baby with an infection it's not screaming, I have an infection. Some babies, it's not a fever, it's temp instability. Up, down, up, down. So it could be a low temp with no good reason, and then a high temp. So it's temperature instability more than fever with a newborn. Any sort of outward signs of infection, drainage, that sort of thing, abdominal distension, poor feeding. They could have some respiratory distress with color changes, whether it's pale, you know, the yellow tone of jaundice,
Sometimes their
petechiae.
abdominal distension is hard to tell also
I know.
because of that barrel shape.
Yeah. One of the things I check on all my newborn patients every shift is I check their belly, but I check bowel sounds, but I also check whether their belly is nice and soft. So yeah, it's cute little pop, like almost like a little pot belly on these cute little babies. But is it nice and soft? Can I hear bowel sounds? That sort of thing. If we suspect infection either before birth or at birth, whether it's like a chorioamnionitis in mom was febrile, foul-smelling amniotic fluid, that sort of thing, we would probably treat the baby as if the baby's going to be infected as well. So an actual or suspected infection with mom will lead to prophylactic treatment of the baby. CBC, obviously, blood and urine cultures, as well as probably a spinal tap for spinal fluid. And then we're just going to watch. And we're going to, depending on what the infection is in mom, will depend on what we treat in baby. But generally it's, I've seen tobramycin, gentamicin, ampicillin. And we just have to wait for the blood cultures to come back. You got your birth traumas, some of which we suspect ahead of, or are afraid of ahead of time, but sometimes comes as a complete surprise. Certain procedures during birth may increase the risk of certain injuries, as we have talked about in the past. The risk factors certainly are the fact that we are intervening with some sort of intervention, whether it's forceps, vacuum assistance, if they get a shoulder dystocia, if that's, you know, that sort of thing. So we have to, internal monitoring can be, lead to more than just a little scrape on the head. A C-section. I've seen babies born, usually the ones that were born rather quickly because they were urgently trying to get them born, that have had lacerations from the scalpel. These are the babies who are not well, the ones that aren't like engaged in the pelvis nicely. Maybe their face was higher in the uterus than the physician expected. So I've seen small lacerations on babies' bodies after a C-section.
My best friend, her eyebrow was cut during delivery.
Wow, eyebrow cut.
Across there.
So you see a scar?
She can't grow her eyebrow down there.
Oh, that's a shame. Color it in. Could have been worse, right? Oof. Could have been her eye.
Oh my God.
Yeesh.
Wait, is this from C-section?
Yeah.
You know, her mom was like, her mom talks about it. She's like, I was a hippie. I didn't know. I was young. I just wanted to get back to the beach with my baby. I'm like, okay.
Oh boy. Yikes. That's funny. Birth injury can be as obvious as a laceration from a C-section, but some are not as obvious. Some might just feel the crepitus with a broken clavicle, or some you might see decreased movement in one arm or the other, that sort of thing. So you just have to, they're not going to tell you. You can ask. The newborn baby will not tell you what happened or how they're feeling. They will tell you. You just have to, they'll tell you a little more subtly. They will not use their words, even if you ask. Yeah, there's a picture of shoulder dystocia, and you can see how the stretching of that neck there can cause some trouble with it, nerve damage in their neck. So they're either getting pulled, their one side or the other is being pulled too much, and it can stretch and cause injury. Like I said, sometimes we can predict the possibility if you take in the whole picture, anticipate an issue. Hyperbilirubinemia. So there's a couple of things that make any newborn baby more susceptible to jaundice. Some bruising, just some normal red blood cell destruction, right? We all just have our red blood cells are always being killed off and, regenerated. Our livers, so the red blood cells are destructed, and the waste product of red blood cells is bilirubin. Our livers process that bilirubin, send it to the GI tract, and we poop out bilirubin. It's the system that's in place. We're all doing it just fine from your skin tones, anyways. All right, send a baby into the same situation with either a little bit more red blood cell destruction because there was some bruising, or there was an ABO setup or an RH setup a little bit. So there's a little extra red blood cell destruction. Cephalohematoma would be a very good reason why there's extra red blood cell destruction. All right, strike one. Strike two, immature liver. The liver's trying to figure it all out, so it's a little sluggish. All right, so it's not processing it as quickly as we'd want to process. Strike two. Strike three, it goes to the GI tract. Well, in the GI tract, maybe the baby hasn't figured out quite yet that whole eating thing. They're not doing very well eating. They're poor feeder. So what happens is you get the bilirubin waiting to bind to the protein of whatever's coming through the GI tract. They don't get what they need in terms of the protein, and it gets reabsorbed back to the liver to only get backed up further. So there's your strike three. Any normal newborn tends to have just a tad bit of jaundice as everything kind of balances it out. Add any extra, the bruising, the blood setup, the poor feeding, all of that sort of thing, and it just compounds the factors a little more. Physiologic jaundice is benign. That's just that whole process that just needs to catch up with itself, okay? It happens after 24-hour mark. And like I said, eventually, within a day or so, the baby kind of catches up with the process. And so we'll see a baby get jaundice, and it will increase to a certain level, usually levels off, and then the baby says, I get it now. The liver kicks in, is doing a better job. They're figuring out how to eat, and then the bilirubin level will decrease on its own. The issue is watching it increase, watching the jaundice increase. The higher the bilirubin, the more jaundice. And, okay, we think this is benign, but how long are we going to watch it increase without doing anything about it? So, some benign jaundice is still treated because we don't want to, and it was helpful, but it's not necessarily going to, it would have gone away on its own had we waited. If it were pathologic jaundice, it wouldn't. In fact, it would just continue increasing to the point of kernicterus, which is it's brain damage and possible death. All right. Sometimes you start seeing a baby with pathologic jaundice start getting jaundice before the 24-hour mark. So they've already started this process of red blood cell destruction and whatnot, like in utero. And they're already jaundiced before 1 day of age. Pretty tough. Or persistently jaundiced after a week old. These are most of the time, either there's some sort of infection or that blood group, the RH or the ABO, mom's O positive, baby's B positive. There might be a little extra red blood cell destruction from that. Kernicterus is a fancy little word for bilirubin encephalopathy, all right? That's when the bilirubin levels get above 25, All right, we don't like to see bilirubin levels. We don't like to see any bilirubin levels other than, we certainly don't like them up 15, 16, 17, above that. All right, again, depending on how old they are in hours, will depend on what level we'll tolerate. All right, but kernicterus, no baby should ever get up above in the 25 range. Again, bilirubin deposits in the brain cells, and if they survive, most have some sort of disability, mental retardation, cerebral palsy, and epilepsy, that sort of thing, because it's just permanent brain damage. Pretty tough stuff.
Is one of the risk factors, like your race? Cause like, do black babies get jaundice more than others?
I don't see black babies getting jaundice more than others.
Than others?
No,
Or
I don't see it.
Or is there like an ethnicity thing or something as far as what?
I don't, the only thing I can think of, it would be the benign jaundice, the physiologic jaundice.
Okay.
This is going to sound kind of, it's not racist at all, but certain ethnicities, like a blood type is more common in certain ethnicities. So if we have two distinct ethnicities, pairing up and creating a baby,
Yeah.
there could be a blood type
Discrepancy.
discrepancy between mom and dad
Okay.
that might lead to
Okay.
some red blood cell destruction. But other than that, I've never seen an ethnic group more prone or less prone to jaundice. That's a good question that maybe somebody should look up for 5 magic bonus points. I don't know what those 5 magic bonus points are going to get you. Anyways, so there are some other risk factors to take a look at too. But this here is a Billy tool. So again, we're looking at age in hours for the baby and what we're willing to tolerate, if you will, in terms of a bilirubin level. And as you can see there, we don't like anything really above 15, 16. You know, as it's getting higher in that dotted, the dots versus the dashes or the solid line, we don't like that a bit. That's high risk, beyond high risk, and we're very concerned. And that is for low risk babies. The solid line is our tolerance level for a baby who's already at higher risk for complications, right? Your preterm babies and that sort of thing. So we just have our level of tolerance. BillyTool.org is what most of our facilities use now. We actually go online, punch in number of hours of age and their level, and will tell us basically what to do. And that's a jaundice kid, appropriate during this pumpkin spice season, right? So yeah, the jaundice is what usually happens, but that's not always the case. I mean, some babies surprise us. They look really jaundiced, but their bilirubin levels aren't all that high. And then some babies don't look all that jaundiced, and we're alarmed at how high their bilirubin is. So that's not the only factor, by all means. The baby that is jaundiced, and not giving us a hard time about being put under the little tanning bed lights. Not tanning bed, it's a UV blue light. We're covering their eyes up with like a blindfold so that their eyes don't get damaged. They're naked, but a diaper. And most often they're in, initially anyways, they're in like an incubator, just for temperature control. And out naked, right? So they don't like that a bit. Right, so the babies who are not giving us a hard time are just laying there passively, Those are the babies we worry about. Yeah. Those are the baby with lethargy, hypotonia. Those are the babies who are really sick. The babies who are ripping out, trying to get those masks off and just really pissed off at us for doing this, those babies are going to be just fine. Those babies aren't sick enough to have those symptoms. So, and I tell that to the parents who, a baby under lights to a new parent is devastated. A new parent is devastated because all of a sudden the baby went from being a little baby to being what looks very sick, right? We're covering them, covering their eyes up. We're putting them in a little incubator. They're just, the lights over them is very, very intimidating. A lot of hospitals now, especially with the rooming in and stuff, are educating their parents on what to look for or whatever. And we're treating our hyperbilirubinemia patients in the room with mom. Yeah.
Do they used to put pennies on their eyes?
Not in my time.
Okay, because I heard that that's what they did. But
The only thing I can think of is the size of a penny is probably just about the right size for the baby's eyes, and then just a little bit extra.
like tanning glasses.
Like tanning glasses, that provides the most exposure to the lights, because that's what it's about. It's about exposure to lights. A baby who's really jaundiced, who has been under the lights for a while, you take their diaper off, you take their little blindfold off, and you can see this. You can see the outline of the.
The raccoon eyes.
Yeah, you see the raccoon eyes. You know, it's yellow here, not yellow there. And in the
picture in that way?
was there one?
The one you had before? Kind of,
Yeah.
maybe.
What's the yeah? Possibly, yeah. So, anyway, so we're moving more towards rooming in and keeping the baby and taking the fear out of the parents a little bit. Like, this is okay. This is why it's happening. This is what we're doing. We have other products, too, that have help with, like, breastfeeding stuff. Billy blankets, flexible tubes of light, if you will, that you can slip inside the swaddle. So they're still getting exposed to blue light, but getting breastfed. Yeah. Because otherwise, if we need that blue light exposure, they might have to cease breastfeeding, pump, and we can feed the baby under the warmer by bottle or by tube or something like that. But it really interrupts the breastfeeding process otherwise. So there's some Billy beds out there that avoid a lot of possible eye damage, where they're in this little crib that has blue lights all underneath them, and then we like basically zipper them in to another blue light on top. So all sorts of different products that are a little less intimidating and assist with continued bonding and breastfeeding. But that looks like a sick baby, especially to a mom, right? When in fact, it's just getting a tan. So we got to watch for everyone. Nowadays, every baby gets what we call a TC Billy, a transcutaneous Billy level, and it's this light. I'm not sure how exactly it works. It's it's a handheld device that we, depending on what facility, and we're doing it on the forehead or doing it on the chest, and we press it, and it flashes this red light, and then it's either 3 or 5 times we press it at the same spot on the baby, and it gives us a TC, transcutaneous Billy level. Based on that, we will, depending on how many hours old they are and what that level is, will depend on what we do next. So we do look that up, and they might say, yeah, you better get a serum level. So then we'd get a blood test. But every baby gets this screening test done, which means that we might catch the baby who's fooling us, right? The baby who didn't look all that jaundiced, but it is end up being jaundiced. So I think now that is pretty standard practice for all newborns. We got some congenital anomalies that we can possibly go through all, some of which we kind of already have, but maybe Robin will cover in pediatrics. Different congenital anomalies certainly have different risk factors. This being a picture of hydrocephalus. Yeah. Spina bifida. I don't know if anyone's ever seen a picture of spina bifida. It's pretty scary. Here's your cleft lip and palate. This is a pretty obvious one, obviously. But there are some cleft palates that aren't quite as obvious. All of a sudden they're spitting milk out of their nose. And we've missed a small fissure in the back of their soft palate. Omphalocele. Club foot. Couple extra fingers. Polydactyly. Down syndrome certainly has some physical characteristics. I mean, I think everyone recognizes a Down syndrome child or a individual. As a newborn, it's not as obvious, but there still are some things that we can look at. The ones that come to mind are looking at the folds in their hands, the palmar creases, yes.
What is loops on fingertips? Many loops on fingertips. What does that mean?
Many loops on fingertips.
Maybe these things?
Do you know how we have these?
Loops and whirls, I think, on your fingertips.
I think they have more of those.
The lines?
Yeah. You got quite a few there too there.
I'm not Down syndrome.
Just kidding.
Full of wrinkles.
Yeah, I think that's what they're talking about. Or might it be the loops
Of the fingerprints? Oh,
around the knuckles? I don't really know.
Or if your fingerprints, they consist of loops and whirls.
Oh, I don't know.
I'll look it up.
How many
Do
are
look it
supposed
up.
to have?
I don't know.
Sorry.
Not that many. No, I'm just kidding. Anyways, the ones that come to mind are the lower set ears. Their eyes definitely take on a different characteristic. There's some, the palmar creases are different in terms of straight across versus what our palms are like here.
Toes wide, these big toe.
Yeah.
Toes what? Big toe, wide, these big.
Wide space, big feet.
Wide.
Yeah, so some kind of interesting characteristics where we can suspect Down syndrome. Obviously, it requires diagnosis with chromosome analysis, technically.
Oh, they have.
The issue with-
Sorry, they're missing a rib.
See? That one we might not know ahead of time.
What is it?
Unilateral or bilateral
Absence of one rib. I didn't know they were missing a rib.
The thing that comes to mind for me is the congenital heart disease. That's what I worry about. Because congenital heart disease is pretty high chance with a Down syndrome baby. So I just worry about that. A lot of times we know ahead of time.
Yeah, my cousin's like almost 60.
Yeah,
So is mine.
Pounds.
it's about the fingerprints.
Fingerprints.
Oh, wow.
All right, so they have more loops in their fingerprints. Interesting.
This is the Alzheimer's patients do
Do
too.
as well.
Interesting.
Same link there.
How many years?
I wonder, does it change?
Right?
No, your fingerprints never.
That's
show.
why I wonder about that.
Yeah. So can you tell if you have Alzheimer's?
Oh, I see it.
Oh gosh, I don't want to know.
Isn't it like that science thing where correlation is not causation
Yeah.
or vice versa?
Interesting.
They live a lot longer though, Towns.
They certainly do. My cousin is almost 60. In fact, next year he'll be 60. He's having a little tough time right now.
Yeah, he's got.
So I'm not sure if we're going to make it to 60, but he's almost there. He's almost there. And yeah, that's pretty unheard of.
Yeah,
Yeah.
it's amazing.
Mhm. So we got all sorts of issues there that I can't possibly take more time in going through. But you can, any particular diagnosis you're interested in, you can look more into.